Hello, everyone, and welcome to the Addressing Diabetes Risk Factors in School-Aged Children, Bright Bodies at Yale School of Medicine webinar. We are excited that you are here with us today. I am Shamika Davis, and I am from the School-Based Health Alliance. The School-Based Health Alliance is a DC-based nonprofit and serves as the national voice for school-based healthcare. Since 1995, the School-Based Health Alliance has supported and advocated for high-quality healthcare in schools. Our focus includes policy, standards, data, and training to support and grow school-based healthcare, particularly school-based health centers. We believe that all children and adolescents deserve to thrive, but too many struggle because they lack equitable access to healthcare services. School-based healthcare is a solution, bringing healthcare to where students already spend the majority of their time in school. When schools, families, students, and the community work together, students win. At the School-Based Health Alliance, we provide technical assistance and training to the school-based healthcare field. At the School-Based Health Alliance, we also support the improvement of students' health through school-based healthcare by supporting and creating communities and school partnerships. A few reminders for today. Today's session will be recorded and will be uploaded to the School-Based Health Alliance website within 1 week. All attendees are in listen-only mode. To ask a question during the session, please use the chat icon that appears at the bottom of your Zoom control panel. When using the chat, please select all panelists and attendees before typing a message. To turn on closed captioning, please click the closed caption icon at the bottom of your Zoom control panel. At the end of today's presentation, we ask that you please complete a webinar evaluation. I would like to share the objectives for today's webinar. The objectives are: participants will be able to learn of the recent publication of the AAP Clinical Practice Guidelines for Children and Adolescents with Obesity, to identify at least 2 risk factors associated with the development of type 2 diabetes in youth, to state at least 1 role the schools and healthy lifestyle programs each play in obesity treatment and diabetes prevention, to define the components of the evidence-based Bright Bodies Healthy Lifestyle Program, and to brainstorm new ways in which schools can become involved in obesity treatment and diabetes prevention. I'm excited today to introduce our presenter, Mary Savoy. Mary has worked in the fields of pediatric obesity and diabetes in both the clinical and research capacity at Yale School of Medicine's Department of Pediatrics for 27 years and the Department of Psychiatry for 15 years. She has authorized and co-authored several research publications and textbook chapters on obesity and diabetes. Over 20 years ago, she developed a family-based pediatric obesity treatment program, Smart Moves, that has been researched at Yale extensively as the program Bright Bodies. Mary has also written the Smart Moves workbook and curriculum for this evidence-based program, and it has been used in over 30 organizations in the US, as well as in Chile and Dubai. Mary is a registered dietitian, a certified diabetes educator, a clinical mental health counselor, and a certified mindfulness-informed practitioner. She obtained her master's degree in mental health counseling after becoming a dietitian because she believes anyone who is helping people with lifestyle changes needs to be an effective and sensitive counselor. In addition to her full-time career at Yale, she has a private clinical practice and a consulting company. She loves yoga, hiking, and cooking, and is married with 3 children. Mary is happy to be here to talk about one of her favorite topics, pediatric obesity and lifestyle interventions. I now welcome Mary Savoy. Mary.
Thanks so much, Shamika. That was so nice of you. It's great to be here. I'm going to go ahead and share my screen so I can pull up my presentation today. So let me know if you can see it. Can you see that?
Yes, we can.
Okay, great. Again, so wonderful to be here. I love working with SBHA, really enjoy it. I guess before I get started, I'd love to know how many of you are actually not nurses in the school-based health centers. Maybe you can put in the chat box if you're not. I mean, I'm thinking most of you are, but I'm curious, you know, how much of the audience is nurse, whether they're nurses, nurse practitioners in the school-based health center. So maybe it's easier to just put in the chat box, and if Shamika could read it to me, how many are not school-based health center employees? Just curious at this point. And I mean, we can just, we don't have to tally it up now. I'll keep talking. I'm just very curious about the audience. So I don't have any disclosures today to report. And as Shamika said, what we're going to cover is we're going to cover some ideas to support the prevention and the treatment of obesity in youth in our schools, because the schools have such a great position that they're in to be able to help children, because kids are there so many hours per day. We're also going to cover the Bright Bodies Healthy Lifestyle program that was designed at Yale. We're going to talk about diabetes risk factor reduction, some grant opportunities that I'm so excited about that have just been released by the CDC in particular, but there's other opportunities as well. And then some steps, like how can you help, particularly whether you're in the school or in another community situation, what can you do to help with obesity treatment and diabetes prevention in our children? So we have a problem that exists, and that is that the rates of obesity have skyrocketed, particularly after COVID. But this is what I could find is the data up to 2020. So for children, and when I say children, I mean like ages 3 to 10 for this diagram, obesity would be about 21%, which is greater than the 95th percentile on the CDC growth chart. And then for adolescents, it's about 23%. And when I say adolescents, I mean 11 years up to 18, 19 years old. So we do have prediabetes numbers for adolescents, and that would be at about 18%. So 18%, which is pretty mind-boggling to me, of our adolescents have prediabetes. We don't have the children's numbers simply because it is not recommended that we have to screen for 10 years of age and less, and those are ADA guidelines. So we, for now, have adolescent numbers to tell us just how much of a problem this is today. I'm very excited. Most of you probably know that the very first clinical practice guidelines for the evaluation and treatment of children in obesity, for children and adolescents with obesity, just came out, hot off the press, end of January. So excited about it. This talks a lot about health equity. It talks a lot about how children with obesity need more aggressive treatment. Look and wait, let's hold off, let's see what happens. That's not working. So we need to be more aggressive with the treatment of obesity so that we prevent type 2 diabetes in children. So the guidelines do talk very much about how much of a role the schools play. We know that children spend most of their time in school, and so therefore the schools are really influential in how much physical activity the kids are getting. We also know that the presence of fast foods, vending machines, sweetened beverages are a problem in the school setting. And we'll talk about some of the efforts that have been made to clean that up. There's a positive association between fast food outlets and the proximity to schools. We know that there's a stronger association. Now I'm quoting this right from the guidelines. There's an association between fast food outlets, grocery stores that are located near the schools, and those who are socioeconomically under-resourced. So all of this is connected. So the schools, where in the vicinity of the schools, the fast foods are, where grocery stores are. And when we say grocery stores, a lot of time it's just a mom and pop convenience store. And we also know that those are definitely in the more socioeconomic disadvantaged communities as well. And we know that the obesity rates are higher. In fact, in the food deserts, the obesity rates are higher. So what are some of the efforts that are being taken now to actually make the behaviors a little healthier in the schools? We know that for years, we've been trying to improve the quality of lunches. We've even made the pizzas with whole wheat crust. So a lot of things have been done. But I have to tell you that I work in an obesity clinic at Yale, and all of the kids are telling me they have pizza every Friday, no whole wheat crust, chicken nuggets, cheeseburgers, and French fries. So I do think that there's still a lot of opportunity to clean this up. And years ago, when we first made the big push for healthier foods, there was a lot of plate waste. I don't know if you know this or not. So a lot of the schools kind of went back to more convenience foods, and it was cheaper overall for the workers to actually take convenience food, frozen foods, and heat them up than make things from scratch. So again, a lot of work that needs to be done in that area. You may have heard that maybe the birthday cupcakes were being cut down on. Definitely ice cream vending went out the window, snack food vending, no sugar beverages in the vending machines. And I think that's been very, very helpful. Something else that particularly I think needs to be worked on is less food rewards, because the teachers are still giving food out as rewards to the kids. And, you know, let's face it, food is a little bit cheaper to buy than, you know, toys for the kids, but, you know, there's stickers, there's things. So I do think that we still have to work on that. Certainly allowing enough time for physical education and for recess and gym. Much of that was decreased over the years to try to get our grades in science higher, grades in math, languages. So what goes? Physical activity. So now the push is to get that back. In fact, the science is showing us that more physical activity increases the grades. We learn better when we have short bouts of physical activity throughout our day. And there is a push for non-stigmatizing fitness programs within the schools. And there's a few schools in particular now that are doing this and are doing a really great job with some fitness programs going on right in the schools. And of course, healthy lifestyle programs. And if it could be within the school, even better. And this is all talked about within this clinical care guidelines. And I'm happy to give Shamika a copy of this to maybe put on the website. If you haven't seen it, just let me know at the end of this discussion, and I'm happy to give a copy to make it easier for everybody to read through it. So I want to throw out a question, because I think there's so many great ideas out there that we can initiate efforts to help kids and to really improve their behaviors. Do you have any other ideas besides these bullet points that I have here? And so maybe put it in the chat box, because I'd love to hear about it. And I'm going to share a few interesting things that I've seen more recently. But for now, I can't read the chat box. So Shamika is going to read them to me because I'm in the presenter mode and I can't see what goes in the chat box. But maybe Shamika could read a few to me. That would be great. So just take a moment and think about any ideas, because I'd love to hear new ideas. I think it would be a great discussion. Things that can be done in the schools that you really, when you look around, it's not being done.
Yes. And Mary, we have formal health class for elementary.
I love that. Formal health class for elementary schools. I love that. I really do. And it would be maybe, yeah, that would be non-stigmatizing. I love that idea. Great. I don't know who gave that idea, but I love it.
Yes, Catherine Newton. And from Lauren And from Lauren Ellis, community gardens where students eat what they grow.
That would be great. There's a few places in New Haven that have tried that. So I'd love to talk with you a little bit more about that later, but I love that idea. Because of course, we're also talking about like teaching kids how to grow food, right? I mean, what's better than that? Teaching them how to grow foods that are healthy and it's more economical. Love that idea.
Walking, biking, running clubs at school from Catherine Owen.
Thank you. Thank you, Catherine. And it's a simple thing, right? We think a walking club, a biking club, and it would bring kids together and they would be having physical activity. I love that. And you know what I love about that, Catherine? I love that they don't have to be good at sports, right? To do that, because a lot of kids with obesity don't try out for sports teams because, you know, maybe they feel awkward or maybe they feel they can't do it. Maybe they feel that they're going to be bullied. But something like a walking club, bicycling, I love that.
We also have healthy cooking classes from Lauren Ellis and from Patrice Toy, farmer markets on school grounds for the neighborhood.
Love both of those ideas. Thank you so much for sharing. Anything else, Shamika?
Yes. And those are the ideas we have for now.
Great, love it. Thank you so much for sharing. I love those ideas. So I want to tell you about something that one of my, I think he's just a dear colleague of mine, Shannon Nags. He works at Troop Elementary School in New Haven, Connecticut. And he is just so passionate about being, he's a nurse practitioner for a school-based health clinic. He wanted to know how many of his wonderful children had prediabetes. Okay, so he wrote a grant, got a point of care A1C machine, and look at his results. He took all the kids that identified as being at risk for prediabetes, so they had to be greater than the 95th percentile. He tested 110 kids. Now, these were fifth graders, sixth, seventh, eighth, because the elementary school goes from pre-K to eighth grade. But out of 110 kids, he had a 38% prediabetes rate. I don't know about you, that's pretty scary, I feel. And I see the same percentage in my clinics. So that's what I'm thinking, like that is a pretty good number that we're dealing with for kids who are walking around with prediabetes. So as we know, the A1C cutoff values for prediabetes is 5.7 to 6.4. And then if it's 6.5 or greater, the child actually has diabetes. That would be full-blown type 2 diabetes. So we love this idea so much that now other schools in New Haven are all applying for a grant for a point of care A1C machine. But I just had to share that with you because I think it's so innovative and I just think it's wonderful. So love to hear new ideas that people have. Of course, some people, on the other hand, believe what good is it identifying kids with obesity, identifying kids with prediabetes? They think it makes no sense for schools to inform the parents when they're actually part of the problem. And while I get that, I still think it's worth it. And maybe you feel differently, but I still feel it's worth it to identify the children who are at risk. I really do. I still think it's such a worthwhile project. But I also get where Dr. David Ludwig is coming from. He's saying, if we're going to be informing, we should be doing, we should be helping. So again, the care guidelines that I was telling you about earlier, they really want to push the healthy lifestyle programs in the community. They want to educate and support families about nutrition, physical activity for long-term health. And we know that to be most effective, it needs to be in person. Now, times have changed. Since COVID, we've done a lot of things virtually. But when the care guidelines were being looked at, all the research out there was in person, and we knew that 26 contact hours over a 3 to 12 month period was necessary to actually see BMI and other health changes, BMI changes over time. So the CARE guideline is saying, let's offer this in pediatricians and other, physician or community physician offices and any other community organization. So I think right off the bat, I think school, why not put a healthy lifestyle program right in the schools where we have an audience, right? We know the kids are going to school every day. And so I think it was Catherine, somebody said earlier, just have like a health class. Well, this is almost like doing that, right? Within the school. I want to share with you 2 schools. There's at least 4 I know, but these are 2 newer schools working with a healthy lifestyle program, particularly the Bright Bodies program, because I went in and I trained the schools how to run the program. Optimus Healthcare, who is working in the West Haven, Connecticut area, they have blown us away with their outcomes. They meet the kids after school 2 nights a week, and I'm not saying nights, I should say afternoon, right after school is over. They meet with a group of kids. Their BMI changes are off the charts, surpassed what we did at Yale with our research. So interestingly, it is a nurse practitioner and a phys ed teacher running the program there at West Haven High School. Branford Public School, phenomenal. It's going so well. They offer the Bright Bodies program, but in the evening. So the parents go, whereas Optimus, the parents are not part of it. They do come once a month, pick up their kid, and they stay for a little education. Whereas with the Branford school system, the parents are actually involved in it. And that is for ages 7 to 16. So I want to throw a question out to the audience. Why do we think schools do not offer these healthy lifestyle programs? And then Shamika, if you can just read me a few answers, but take a moment in the chat box and just give me the reason you think they're not offered.
Yes, Mary, from Catherine Newton, we have, they don't want to offend families.
Yep.
From
So
Catherine,
now that kind of goes along too with what David Ludwig believes, like why are, we're getting into like family problems. But anyway, what's the next one, Shamika? That's a good response.
Yes, from Catherine Owen, lack of area resources / appropriate professionals to conduct classes.
Yep.
We
Anything else?
Yes, can't afford it. Also focused on academics. Another response, not offered because there's no money to support them. Another response, staffing challenges / time commitment. Another response is concern that this will not be enough if families do not have financial resources to sustain a healthy lifestyle.
Okay, so what I'm hearing mostly from people is lack of resources, lack of money, lack of professionals to do the job. So I want to give you a quick idea. And I said the same thing, but I just want to give you an example of why I don't agree with that anymore, because I used to agree with that. That's why I say, does it take a village or does it not take a village? The Branford Public School system, there are 9 of us, 9 staff members for 30 families that are in the program. And it's because there's so many volunteers, so many students. Optimus Healthcare, there are 2 staff members, 2 staff members, a nurse practitioner and a gym teacher. They are blowing the Branford Public Schools outcomes out of the water, blowing Yale out of the water. I think you need dedicated people. And yes, I agree it's expensive, but I do think we need to start somewhere, okay? 1 or 2 people. I mean, basically when I started the program at Yale, there were 2 of us. It was myself and an exercise physiologist. We had like 8 families and we started something. You have to start something. So I'm going to sort of challenge you and say, be that villager. It doesn't necessarily take a village. I don't agree with that anymore because I've seen too many successful programs with very, very few resources. So I'm just going to leave you at that because I've seen it. We've done another school in New Haven that did phenomenal. The grades improved in the kids, and there were 2 people there that did it. So again, I think that's kind of the myth that might be out there. And for the most part, it is expensive, don't get me wrong, but you can try to do something, even if it's not sort of the ideal. So here's the Bright Bodies program that was developed at Yale. It's a 12-week program, and we ask families to take consecutive 12-week sessions. 2 times a week, the children exercise. Once a week, they go to nutrition with their parent. And then when we have a behavior modification topic, the children go on their own, and then the parents go to their own support group. So it's a very comprehensive program. When we went virtual, we didn't have the parent class anymore. So perfect example of it's not always going to be ideal. For 2 years, we went virtual and we didn't have parents involved. If they sat in the nutrition part, but when we went to behavior modification and talked about eating triggers with kids, etc., we did ask the parents not to be in that. And we didn't have parent classes because families didn't have 2 devices. So it doesn't have to always be the ideal situation. Our philosophy is to use a non-diet healthy food choice approach. And what does that mean? It means to make the best choice you possibly could. When you're going through the cafeteria line and there's 2 choices, try to make the best one, okay? Nothing is perfect. We don't give you a diet to follow. Make the best choice. Healthy cooking methods we talk about, decrease portions. So this is all what we call a non-diet way to eat healthier and for weight management. We do ask, if possible, a parent or caregiver be there with the child or the adolescent, again, if possible. Our program is for kids 7 to 16. Every year we make it younger and younger and younger. And what is that telling you about the times, right? We used to start at 9, then we went to 8, 7. I'm telling you now we have 6-year-olds in the program, and we have 18 and 19-year-olds in the program as well. And our philosophy is for greater than 85th percentile, because it is about a healthy lifestyle program. And we do let siblings exercise with the kids and be part of it. But for the most part, the child needs to be greater than the 85th percentile. I'm hoping you have all seen this extended BMI chart, because while I say our kids are greater than the 85th percentile, our kids are up here, okay? So I love this new CDC extended BMI chart. And the reason I love it is because in the past, we had a CDC BMI chart that just went to greater than 95th percentile, and all the kids were off. They were completely off the chart. We would just put a little arrow. Okay, so how do you think that made the kid feel when we showed them the chart? Okay, you're off the chart. Now they're in the game, okay? Now we can show them where they are. And for those who don't know it, the 95th percentile and above is obesity. But from 120 to 140 is class 2 obesity, and greater than 140 is class 3 obesity. And we know that the higher the class, the higher the chances of the child having type 2 diabetes, having fatty liver, having asthma, having all the, high lipids, all the comorbidities that go along with having obesity. So the higher the percentile, sort of the higher the risk of the child. And I just want to note here that the Bright Bodies program that we developed, actually the children in the higher percentiles do better. And so that's very interesting, because those kids tend to be much harder to treat. Once a kid goes greater than 140th, they are much harder to treat. So I was excited when we did some research and saw that. We're back in person. We also have a 100% virtual program going on simultaneously, because we're finding that, the silver lining from COVID was that, we did this program virtually and we were able to extend to other geographical locations. We actually have people in Michigan joining us. We have people in Ohio. So we not only were able to get the Yale vicinity, but we went beyond that with a virtual program. But we're back in person, and we're using the Brantford Public School, and we're using a clinic in New Haven on Long Wharf. And we've always had the program going at the John Martinez School as well, and that's run through Fairhaven Health Center. This is just a flyer that shows, this is just perfect to see these 3 logos here: the Brantford Public School, Yale School of Medicine, and then Yale New Haven Health. Love the idea of the gardens that someone mentioned. I would love to even put, because there is a garden in New Haven, and you're giving me ideas, and I think it's great to add something like that. The school-based health center, John Martinez, I'll go back one to show you which one. This one here, they have a garden that they are associated with, but at Yale we don't. So, and it's something I probably should start working on. I just love that idea. So I'll quickly tell you about our lifestyle curriculum. It's a 120-page workbook. It has a parent's guide within the workbook. There's an instructor's manual to go along with it. We have nutrition topics, and we have behavior modification topics. Some of the nutrition topics have actually been written by the parents. We really use a patient-centered approach with the program. The parents and the kids kind of are part of it, whether it's they come up with their own solutions, they come up with some of the materials. We have a newsletter, the kids write some of the articles in the newsletter. So it's sort of like a co-op, if you will. And the behavior modification topics might be something where we're helping them identify an eating trigger. You know, what are some of the high-risk situations? We help them identify it. And then it's a two-part topic. The following week, we go into how to cope with it. We talk about bullying, and for the first time, kids are hearing that they're not the problem, but the person bullying is the problem. And we get them to be sort of compassionate about the person who's bullying them. Like, what could possibly be going on in their lives that they have to bully you because you have a weight issue? So that's a great topic that we do. And then understanding a relapse, which is basically part of any healthy lifestyle curriculum, you know, because we're not going to be perfect and we're going to slip back every once in a while. So how did we start this non-diet approach in our program? I always, you know, I was always against dieting. I actually was a heavy kid myself. And the more I dieted, the more weight I gained. Every time I dieted, I think I gained another, I don't know, 10 pounds or so. But anyway, when I started this program, I knew I didn't want kids to diet. So I was being challenged by some of the parents. They would say to me, Mary, you know, I'm floundering from this non-diet approach. Could you give me something to follow? So I would give them a structured meal plan, and it wasn't really rigid, but it was something written by the American Dietetic Association. And it would say how many starches, you've all seen it, how many starches, how many proteins, how many fruits, how many vegetables per day. So some of the kids were following that. But I continued to see, is there any difference between the groups? So the kids that continued with the philosophy of the non-diet approach are depicted here in the solid line, while the kids who use the dieting approach is depicted by the dotted line. The solid line is the non-diet approach. At 1 year, I said, oh my gosh, maybe I made a mistake because the kids who dieted did better. But sure enough, by the 2-year mark, this is years, and this is BMI Z-score. So by the 2-year mark, the kids' weight, their BMI had bounced right back to baseline, which, as you know, is the hallmark of dieting. You lose it, you gain it back. So this reinforced to me in 2005 that I was indeed using the right method with the children. The other thing about dieting is I think it makes adults feel bad, but it makes kids feel bad about themselves, right? They can't follow it exactly, so then they beat themselves up. So we don't want that. So our overall goal for behavior modification is to help the child replace the negative behavior that they're doing, right, with a positive, healthful behavior, because we're working on their self-image. This is a critical period for kids. We want them to feel good about themselves. So we do a lot of work with self-image, self-concept. And this type of a class is taught by either an RD or a social worker. And it's 40 minutes for the older kids, 30 minutes for the younger kids. We use self-awareness, stimulus control, and we always use the client-centered approach, always. So self-awareness would be that risky business topic I told you about, where we teach them to identify an eating trigger, and then we teach them to cope with it. Stimulus control would be something like teaching the kids, so that topic is called environmental engineer, So the kid would come home from school. We use this as an example. Many kids will just eat the minute they walk in the door when they get home from school. And maybe there's potato chips on the top of the refrigerator. So they grab them and they eat. So stimulus control is about, okay, don't keep the potato chips on top of the fridge, because you know what you don't see, you don't think about. Or maybe don't even bring the potato chips in the house at all. Maybe you can go shopping with mom or dad and really tell them, let's not buy potato chips. And then the client-centered approach, basically, we have the kids come up with their own solutions. And there's a topic called alternative activities to overeating. And kids come, they love it. We build a collage during that week of all kinds of things that we can do, that we love to do, and that something that sort of defines who we are. And as I said before, we do want to offer the parents and caregivers ways to support their child in the home and to make the home conducive to healthy lifestyle. And they go to the parent class when the kids are in the behavior mod topics. Because simply we want to separate them and have them have sort of their own time to discuss things. And parents want to discuss things without the child. One of the topics we do in our parent support group is we talk about the child's strengths. And there's usually not a dry eye in this class, and I'm going to tell you why. As parents, whatever our kid is going through, we tend to really zoom in on that problem, right? We have to fix it. This is horrible. We have to fix it. And so we lose sight of all the other great things going on with the child, maybe great characteristics that they have. So parents realize for the first time in these support groups that, wow, you know, my kid, I'm not thinking about all these great things that my kid does. I'm thinking about how they're sneaking food all the time and how they're eating too much. So it's a really great exercise that we do with the parents. And then lastly, I want to talk about the physical activity component. We really want to instill the sense that physical activity can be fun. And we put the kids in the same age group simply for safety purposes. So 2 times a week, 45 minutes, 7 to 10-year-olds go in one group, 11 to 16-year-olds in the other. And we encourage them to exercise at least 3 other days in addition to Bright Bodies. And I know the guidelines, whether it be the Sports Academy or whether it be the AAP, all say 60 minutes per day, and that is wonderful. But a lot of times kids that start with Bright Bodies are doing no physical activity. So to think 1 hour every day is kind of too high for them to reach. So we go with 45 minutes, 5 times a week. Our buddy system welcomes new members, and we really have found that it increases retention in the program. The kids have a friend the minute they get there. They make more friends, and it's a great program. So that's Eric to the right. He's not really a typical Bright Bodies kid. He has lost over 100 pounds. But after 20 pounds, he came off his metformin, came off of his insulin, and he actually doesn't have, even today, he uses no medication at all. We've stayed in touch with Eric because this is an old file, an old picture, and he comes and talks to the kids once a year, actually, in the program. So he's a guest speaker for us. Some of the ways we measure success is through body mass index, looking at % body fat, and we look at insulin resistance. And there's a formula for that, HOMA-IR. HOMA insulin resistance formula is taking fasting insulin, adding fasting glucose, and then dividing it by 22.5. 5.35 is considered insulin resistant for the child if it goes up that high. And then we also look at self-concept scores. We use a Pierce-Harris self-concept index. So we do that before, and then we do that 24 weeks later. So these are some ways that we measure success. And I just want to share a few with you today. We had a 2-year study that was published in Pediatrics. And this really put us on the map because our program is not just all Caucasian kids. In fact, about 30% Caucasian, and then about 40% Black and maybe 30% Hispanic, or a little bit higher than 30%, 35% Hispanic. So we really have a mixed ethnicity. And so this put us on the map for two reasons, for that, and also we had positive outcomes. So it was very different from some of the other studies that were out there. But take a peek at the 2-year mark. And we did nothing, by the way, from 12 months to 24 months in this study. We did absolutely nothing. The first 6 months, kids were either put in a control group where they stayed with their physician, or they were put in the Bright Bodies program, and they met 2 times a week for the first 6 months. From 6 months to 12 months, the kids came twice a month, like a maintenance program. And then from 12 months to 24, nothing at all. We wanted to see what the kids learned. Sure enough, the trajectory here is so much lower. It's much steeper in the clinical control group. But the kids did not go back to baseline. And again, two different directions, which you're going to see a lot of when I show you some of the research. Control group going one way and Bright Bodies going the other. So once we knew that we were really good with kids with obesity, we said, let's go and try to help the kids that are on their way to diabetes. So we did a prevention of type 2 diabetes study with some of the schools and some of the community physicians. And what we found was pretty exciting. But I first want to, before I get into that, talk about some of the risk factors associated with type 2 diabetes. These are the things we were looking for in the study. And we went to each physician and we went to each community and school, each community organization that we were working with. And we said, okay, we're looking for BMI greater than 85th percentile, a family history of type 2, specific race, Hispanic or Black. We were looking for sedentary lifestyle, poor diet, acanthosis nigricane. Now, this is obviously a very severe case of acanthosis nigricans, but this is what it looks like. It's from high levels of insulin, from that insulin resistance we just talked about, high levels of insulin that come to the surface of the skin and changes the pigmentation of the skin. When you see a child with that, the light bulb should go off automatically that the child needs to be screened with maybe an oral glucose tolerance test. And then, of course, if someone had an increased 2-hour glucose for an OGTT, that was a risk factor, hyperinsulinemia and dyslipidemia. So this is how we diagnose it. There's 3 different ways. I'm sure everybody here knows. We talked about the A1C diagnosis. Fasting plasma glucose, 100 to 125 is pre-diabetes. Greater than or equal to 126 is type 2. And then the oral glucose tolerance test is sort of the gold standard. When you do an oral glucose tolerance test, you're challenging the child with 75-gram carb load. We give the kids like a glucola to drink, and it's got 75 grams in it. So we get a fasting and we get a 2-hour when we do an oral glucose tolerance test. So it is a great way to actually diagnose a child with prediabetes or type 2. So going back to the study that we did, we went in the community and we said, try to send the child to Quest and see if they have impaired glucose, if they have impaired glucose tolerance, which is greater than 120 at the 2-hour mark or greater than 140. So what we did was we screened them in the community. They came back to Yale. We validated that they indeed were impaired, and then they went to standard education or Bright Bodies. And then we checked them again 6 months later. What we found was a difference in BMI, a decrease in Bright Bodies. The control group's BMI went up, again, 2 different directions, percent body fat the same, and fat mass the same. Even weight, we didn't expect to be statistically significant, but it was. So we didn't have as good of results as we had in some of the other studies that we did, but now these were kids with prediabetes, and so it's a lot harder to treat them. More impressively was the OGTT data that showed, you can see at baseline, no differences between the red group or the blue. The red is the clinic control group, and the blue is the Bright Bodies group. So no differences at baseline. However, after 6 months, you can see that there was a difference at the 2-hour mark with the glucose. We didn't expect a 25 to 30 milligram per deciliter difference. But we did expect insulin, but not 100. There were 100 microunit per milliliter difference in the kids that were in Bright Bodies versus the clinic control group. So this speaks volumes. And we did have 45% of the kids go from IGT to normal glucose, and 2 kids in the control group actually developed diabetes. So again, interesting information. So ways to make a referral. So if you want to refer someone to Bright Bodies, and again, keep in mind that we have the virtual program. So even if you're not geographically, in the area, in the New Haven, Connecticut area, you can still send your child to Bright Bodies or your patient to Bright Bodies simply by calling us, because we can put you in the virtual program. So if you want to make a referral, we have, you can call us, you can go on our registration page, which is actually under construction right now. Next week, our website will be done. And then you can email myself or the coordinator, or you can send an Epic in-basket notification, as long as you have the MR number. And of course, you have to have the Epic system. I am so excited that we now have grants available for healthy lifestyle programs. This was not the case before. There were very few of them, but the CDC has now endorsed our program, and we are listed among, there's about 3 on some recent RFAs that came out. There's about 3 programs, and we're one of them. So I would definitely encourage you to reach out to the CDC, go online. They're looking for states, so it can be a statewide project. It could be within a university, any community. I'm thinking schools. I've already got phone calls from schools that want to utilize Bright Bodies. So this is money being given to you from the CDC to start a healthy lifestyle program. Also, the American Diabetes Association has some great grants that are out there. So this is all, wonderful information. This is so timely. We have to do something about it. And so I would definitely recommend, if you're low on resources, to check that out. But again, getting back to what I said earlier, you've got to start somewhere. It doesn't have to be perfect. So, one villager at a time. And so I would encourage you, and I would challenge you, to be that villager, and to go out there and get started. And even if it's with a few families, even if it's just you and one other staff member, maybe it's just you, but do something and, be creative. So I would definitely recommend that. So now I'd like to just take some questions. If you have any questions, whether it be about Bright Bodies, healthy lifestyle programs in general, prevention of type 2 diabetes, childhood obesity treatment, I'm going to stop my share, and I would love to take some questions. Shamika, I don't know. I can probably read the chats now. Let me see if I can. Oh, I can see them. Yep. So I just got something from Lauren. Can you go back? Let's see. Let me read these chats. Let me see. I might need your help, Shamika, but if not, let's see.
Yes, I can. I'll begin sharing my screen.
Any questions? Because I don't think they can ask them live, correct?
Yes, I believe you should be able to unmute.
Yeah, if someone has a question they want to ask live, or put it in the chat box. What is the charge? Does Bright Bodies charge people for the program? Okay, thank you for that question. We use a sliding scale. We are working on insurance reimbursement right now, and that's been going pretty well. But until we're there, we are charging out of pocket for families, and our sliding scale runs from $0 to $200 for the 12-week program. And so if a family has, let's say, less than $45,000 annual income, it's waived, and then it goes up, and then it could be $50, it could be $100, $150, or $200. So that's how we get some money for the program through out of pocket. Great question. I think there was a question before that one, but I don't know if it was similar. Once it is determined that the child is type 2, are most practitioners starting treatment in clinic? Yes, they are. In fact, we don't recommend that you wait until they have type 2 diabetes. That's why finding out if a child has prediabetes is so important. Usually by prediabetes, we are giving them metformin. And I'm hearing that some physicians are actually, I don't know how comfortable some of you are with GLP-1 analogs, but that is like a big thing right now. So if the child has type 2 diabetes, we can try to get Ozempic for them. What's harder to get for children is Wegovy. So it was approved recently by the FDA, Wegovy, but it's very hard because insurance companies don't cover it, or the employers are not, they're not covering the rider. So in other words, what I've learned recently is it's not just the insurance company that needs to cover the medication. It is that the employer needs to purchase the rider. So that's been a huge barrier to using some of the treatments that we have. Of course, the first thing we do is we have the children do a healthy lifestyle program before we would even address a GLP-1 analog. Do you start new cohorts for virtual programs frequently? Yes, we do. We start new cohorts every 12 weeks. We do allow, we have what's called an open program, and that is that we'll let newcomers in up until week 6. And then after week 6, we say to wait till the next one. So we go 12 weeks, take a few weeks off, start a new one. Let's see, I don't know if I'm probably not keeping up with all these questions. I'll try, give me. This program would work well in my area. However, virtual is not always an option. I get it. Yep. Utah, Navajo Reservation. So we are working now with a reservation in Michigan. I was telling you that we're helping Michigan. That is a reservation. And so we're working with them, and you're right. Sometimes it doesn't work because there might be internet problems. But I will say that there's been more good done, and it's been worth it. It's definitely been worth working with the reservation that we're working with. Shamika, Bridget is saying the evaluation link is not working. I don't know if you rectified that already. And then the next question by Lauren is the only requirement 95th percentile, or do they need to be pre-diabetic? Absolutely not, no. The only requirement is actually greater than the 85th percentile, not even the 95th percentile. I'm sorry if I might have wrote 95th on one of the slides, but to get into the Bright Bodies program, the child should be greater than the 85th percentile. Of course, you can make, Lauren, whatever criteria you want for a program. But if you wanted to get into our existing program, yes, greater than 85th. We're hoping to have the child not end up with prediabetes. So that's kind of our goal. Oh, you're welcome, Lauren. I'm going to see if I got all the questions. I'm scrolling back to see. On your demographics, do you have Pacific Islanders? We do. We have very few percent, but we do have some Pacific Islanders. It's so interesting, though, because we have actually been asked by people in the area, different islands, that they want to start doing Bright Bodies programs. So I'm super excited about that. So I would when that time comes, I think it'll be awesome. But yes, we do have some that are part of the demographics that I've been reporting on. I'm just going back and scrolling to make sure I did not forget any question here. Are there charges for the program? I already talked about that. Right now, we are trying to work. We have our biggest barrier has been Medicaid, believe it or not, trying to get the insurance companies to pay for the programs. Most of our population is Medicaid state. And so that's been our barrier because they don't pay for healthy lifestyle programs, if you can believe it. Don't even get me going on that topic because they do pay for these GLP-1 analogs I just told you about, but they don't pay for a healthy lifestyle program. Anyway, we could probably have another whole conversation about that, another whole PowerPoint presentation. Any other questions at all? I think we have one more minute. Thank you so much. And is there another question, Shamika, before I log off?
Yes, thank you, Mary, very much. Thank you for a wonderful presentation on the Bright Bodies program. It is greatly appreciated.
My pleasure.
Yes, thank you. The evaluation link for this webinar is available in the chat box. A recording of today's session will be uploaded to the School-Based Health Alliance website within 1 week, and we will also send you an email for when the webinar is available.
Thank you so much.
You're welcome. And I would also like to announce that the National School-Based Healthcare Conference will take place in Washington, D.C., June 26th through the 28th, 2023. And registration is now open on the School-Based Health Alliance website. Again, thank you, Mary, for a wonderful presentation. And thank you all for taking the time out and joining us today. It is greatly appreciated. If you have any additional questions, please feel free to contact the School-Based Health Alliance at info@sbhforall.org. And I hope everyone has a good rest of your day. Take care and thank you.